We're delighted to have a visiting speaker virtually visiting us from Calgary, Dr. Pietro Ravani. Welcome, Pietro, and thank you for getting up early in your time to do this. I'm going to hand this over to Manish, who's going to give a more formal introduction of Dr. Ravani. Manish.
Thanks, Greg. Dr. Ravani is not only a practicing nephrologist in health services research from the University of Calgary, he's also an outstanding epidemiologist and friend. He's a full professor now in the Department of Medicine at the Cumming School of Medicine. He's a member of the O'Brien Institute of Public Health with outstanding contributions in the field of epidemiology, and a member of the Libman Cardiovascular Institute of Alberta. He is a current holder of the Roy and Vi Zai, I hope I said that correctly, Bay Chair in Kidney Research. He has a varied background in that Dr. Ravani trained in Italy, received his MD in Nephrology Fellowship at the University of Parma, his MSc in Statistics at the University of Pavia, and his PhD in Clinical Epidemiology at Memorial University of Newfoundland. So a very nice, varied training background. He currently holds funding from CHR, the Kidney Foundation of Canada, where he's looking at outcomes of hemodialysis access, use of home therapies in people with kidney failure, outcomes of kidney transplant recipients with a failing graft, and treatments of nephrotic syndrome. And his portfolio is very broad and includes national and international trials. His most recent CHR grant supports studies on the trajectory of chronic kidney disease with aims to improve clinical outcomes and optimize the use of healthcare resources in this large population. And I'm very happy to introduce Dr. Ravani today, who will be presenting our Ottawa nephrology grand round. Please take it away when you're ready, Pietro.
Thank you. So should I put the bigger screen, or this is better? What's best? Should I make it full screen?
Make it big, Pietro.
Make it big.
Yeah. This is okay? Yeah.
Perfect.
Okay, so thank you for having me, and thank you for the nice introduction. And it's wonderful to see the faces of friends in Ottawa that I would like to visit soon again, hopefully to talk about some other nice papers or research that we are collaborating with. So some of these data that I'm presenting today are actually data that came up from work together with Manish, and we have a couple of papers that are in press. The last one is about a regression of CKD that I will mention during the talk. So the title that I gave to the talk is mostly related to the fact that we all hear that the global population is aging, and this is probably a fact, but we all hear that CKD is a very heavy burden for globally, and there is even a thought that this burden will increase. And so the question is, how will this affect our service? So I just present this quickly because it's standard, but I noticed the University of Calgary suggests also to ask participants to send email feedback if they notice anything that deserves some improvement. And please, I ask you to do so. Okay, so I divided the talk in three sections, and the first two ones are actually the presentation. The last one is more about the implication, where I would like to be brief and give space to questions and discussion. So first of all, is this global epidemic a fact or a fiction? What do we know about it? What can we believe? Yes, probably we can believe, and we see this is documented. There is an increase of the aging of the population. The fraction of people about age of 65 increased from 5% in the 50s, and in 1 century is going up more than 3 times. And we see this is the direction. More people are living on the planet, and most of them are elderly. I don't think we can consider this a fiction. It's probably a fact, although the distribution of age increases mostly in the Western societies. But what this starts to become a little bit, I would say, debatable is the inclusion of chronic kidney disease among the 10 most common conditions in the elderly. So in this report of the National Council on Aging, it is placed at the sixth position, the sixth position after hypertension, cholesterol, arthritis, and etc., diabetes, with the prevalence up to 18% in some studies. In a recent publication, we actually saw that there is an increased incidence of chronic kidney disease with age. I intentionally blanked the last group of bars in the age greater than 85 for renal replacement therapy because I want to get into that later. But you see that both for the incidence of chronic kidney disease and to some extent the incidence of renal replacement in Alberta, these are provincial data using population demographics from Canada, there is an increase that parallels aging. Why we are worried about this and why we are discussing, and funds are available for chronic kidney disease research and have been increased in the last 20 years because CKD outcomes are poor. But I would like, this is a study that is now more than 10 years old from Brenda, and what I would like to draw your attention to is not just that with the decreased GFR or increase albuminurias, if you go, I don't know if you can see the pointer, is it? Yes. So if you go left to right in each of the groups of different diseases, from normal to heavy proteinuria, or if you go down from normal down to a lower GFR, you see that the rate of events increases to 7 to 9. And this is for all-cause mortality, myocardial infarction, and stage doubling of serum creatinine. If you look at this kind of a relationship, which is specific for everything that concerns cardiovascular disease, an epidemiologist might start thinking lack of specificity doesn't really support causation according to the Bradford-Hill criteria. But this is what we know. Outcomes associated with proteinuria and decreased GFR are poor. And this is the first, so I go back to the previous slide, and this is the first work that we have done to address the question of whether renal replacement will increase with population aging. And we really started to see that some registries, like for example, the Australian New Zealand report the splitting of age categories at 75, 85 and above. But many other registries, including the USRDS in the previous version, I don't know the last one, doesn't split and shows an increase in the categories up to, I think it is 75 and above. However, when you look specifically at the very elderly, which is a large fraction of the elderly population, this trend is interrupted. However, it is true that severe chronic kidney disease, the incidence of severe chronic kidney disease increases with age. Why in the elderly we might not see the increase of the probability, the risk of kidney failure in the elderly? Well, one of the explanations is probably the competing risk for death. And in this study, we show this is, I think, already published, yes, 2019, so I can definitely refer to this more deeply. We can see that the area, the probability of kidney failure or developing kidney failure over time is far bigger than the risk of kidney failure under the age of 65. But then just at the age 65, 75, the mortality takes over. So why are we debating, or why are we discussing this issue of the global aging and burden of chronic kidney disease? Well, because we all know, even non-nephrologists know, that existing data have limitations. When we talk about the burden of a disease, we usually refer to the prevalence, although, burden is a bit ambiguous and we can go back and forth to the incidence and prevalence. But what are we referring to when we mention and we start our papers usually with the sentence, the CKD burden is as high as 10, 9, 10, 11, 15%. Well, we refer to a disease that is defined not really according to the KDIGO recommendations. Although this is not graded recommendations, it reflects what we in practice do. In practice, we want to confirm the decline of the GFR with another measurement, ideally after 90 days. Well, in most studies, this is not done. So the KDIGO give also an interpretation of what can be the reason for the kind of GFR that is not confirmed. CKD is not confirmed, or the patient might have acute kidney disease, may still have chronic kidney disease, but you know, some studies like the one that we recently completed, you know, raises the question of whether there might be nothing behind. It might not be chronic kidney disease and may not be AKI. But I said, even non-nephrologists acknowledge that the data have limitations, despite the reporting of this CDC 2019 of up to 15% of the adult population have chronic kidney disease, which is especially high in the 65 and above. There is a note that is probably neglected by most that says that these estimates are based on a single measurement of albuminuria or serum creatinine. And if you look at the systematic review recently published by the CKD collaboration, Global Burden of Disease, the estimates go up to around 9%, more realistically than 15. But again, this systematic review is based on study like this one that reports, this addresses a different question, but reports again in the note you see highlighted below that these definitions were based, followed the practice guidelines in terms of cutoff, but no studies. Repeated measurements after 3 months. So the chronicity criteria was not applied to the definition. So there is one prevalence study that we know and is a very interesting report. This more reasonable figure, reasonable or anyway, let's say different figure of prevalence in Iceland. And this is a relatively well done study using administrative data. So there's some limitation about that, but the coverage of the population in Iceland is very good. And we have less than 6% following the KDIGO criteria of 2 measurements. If they change the thresholds using an age calibration, results are different, but this is going to be the topic of another talk because I decided just to focus on the 2 measurements in our study in this presentation. You see, we have a 6% versus the 9, 10, and above percentages reported in studies. So key points of this first section of the talk. With population aging, there is an incidence of CKD as we define it, but even in the study where we used a chronicity criterion we see now in the next slides, yes, probably the CKD incidence increases with advancing age. Kidney failure may not for different reasons. Using one single measurement to define CKD results in overestimation of the CKD burden, probably. It might also induce a biased outcome estimate because if you include, depending on the extent to which you include acute cases in your population with a single measurement of the GFR or people that can regress, you really don't know what the outcomes that we estimated in these populations are. For the lower risk of kidney failure with a very old age and above a certain cutoff of age, comprehensive assessment of all possible outcomes is necessary. Proper outcome assessment, and I go back to the competing risks that we would mention toward the end of the presentation, and also probably overdiagnosis. The fact that reduced GFR and increased albuminuria are non-specific outcome predictors should also be considered in our when we read papers and when we plan future studies. So let's get back to the question now. So there are limitations in the data. Well, what can we do better to understand what really the CKD burden is in the population? So we can either directly assess the prevalence, and one way is to use administrative data, challenging but possible. Certainly do a direct estimate of the prevalence using a prospective study is challenging, because that means go back to the same person after 3 months, and it is going to be expensive, it's going to be difficult. But there are also indirect ways to do this. So the epidemiologists have this nice, if you just Google and you find in the website referred to below, this bathtub that includes not just the incidence of a disease, death, but also the recovery of the disease, So can chronic kidney disease improve? Because this is important, because we can actually use, administrative data can be used to estimate prevalence directly, but also to do some modeling. And if you rigorously measure the incidence, it might be interesting to compare results of a prevalence assessed directly and a prevalence derived indirectly from the incidence. How? Well, depending on how many new cases you have per year and the duration of the disease, you can derive the prevalence in a modeling study. So what incidence data do we have? This is the study that I was referring to. We looked at G3AB and G4 CKD in Alberta. We used two algorithms that one of my PhD students developed following guidelines recommendation, and very few studies available on what we mean by sustained eGFR within a certain range, and using an average method to define this sustained. And these are overall the definition. In essence, what it means is sustained, that all the values in the series are within the definition of the stage, the range of the stage. In the average method, you allow to vary, but they all have to be within 15 to 60 to define a CKD, and the average has to be within the limit of the specific stage. And this is what we apply. We use the average method for the sensitivity analysis and the sustained methodology for the main results. We looked at qualifying period for each individual, the period during which you have these measurements. They have to be at least 90 days apart, and all the intervening measure within this time are the ones used to do the average, or they had to be within the limit of the stage. We used prior data to exclude non-CKD before, using the same methodology. eGFR less than 15, any. So acute cases are excluded. Kidney replacement therapy. And we use also this period to identify SCR and define comorbidity. And then we look forward to look at all-cause mortality, kidney failure with chronic renal replacement, and sustained eGFR less than 10. So what we found is, again, as for the stage 4, we have, you see the stage 4 again appears here, the one of the previous study, but this time we have also the same trend as expected, that as people age, the incidence of mild, moderate, and severe chronic kidney disease increases. This is true in women and men, as defined in the database. And interestingly, for this presentation, I wanted to look at how much smaller these numbers are as compared to what we know from previous studies that use the same databases. You see that G3A in age group less than 65 is so much higher, 315 versus 132. And you see these numbers always are large, and these are based on one single measurement of eGFR. So in this study at that time, the tendency to use one single measurement was even more common than today. And you see, using one single measurement, yes, increases, overestimate the incidence in the same population if we want to implement a chronicity criteria. What about the CKD outcomes? I mentioned that we need to be very comprehensive, and and consider all possible things that can happen in this population. Death is one of them, and that's known. But what about regression in addition to progression or reaching G5? And for progression and regression, we followed again some recommendations that are reported in the KDIGO guidelines. I don't know who actually came up with this idea, but we found it was reasonable, and I hope you agree with that. So a progression can be sustained, changing category, stage, for more than 3 months, but there must also be an increase of at least 25% of the GFR, because everybody knows the cutoff of the stages can be considered arbitrary thresholds. So somebody that is 29 and then it is sustained 31, is it regression? Has to be also not just a change in the stage for 3 months, but also a change in the percentage of the GFR above something meaningful. And what's recommended is 25%, and we follow that recommendation. So what we found is in all the stages, mild, which is G3A, G3B, and G4, of course, the more severe CKD, as expected, as reported already, there is an increase in mortality. But what's interesting is that not only the kidney failure, the risk of kidney failure, these are probabilities of 5 years, accounting for, so these are competing risk probabilities, crude, okay, just stratified by group of mild, moderate, and severe CKD. So you see that the risk at 5 years increases for progression and kidney failure. So here the risk of kidney failure is very, very tiny. So we decided to put it together with the progression, because mild CKD, the risk of kidney failure at 5 years is very small, and also for moderate. Here, the progression is minimal, and so this is why the colors have changed. But what you see, probability of regression at 5 years is pretty high. So it's something that we see in practice, and sometimes we just put together with the stability of the disease. But some people may actually change stage. When we stratified by age, we, of course, saw within each group of each stage, there is a direct association between mortality and death, the gray bars. But what's interesting is that there is not really, except for the mild CKD, where you have a trend toward less likely regression with advancing age. For all the other groups, yes, maybe it applies also to moderate, but for the severe, for example, it doesn't change with age. Certainly, the progression and the risk of kidney failure decline with age, and we have either a less steep decline of the regression or no decline at all in moderate and severe CKD. Proteinuria is something that makes the difference a little bit. I mean, the general concept is still true, but if you see these dark gray areas of probabilities, you see that, yes, with normal or mild albuminuria, probabilities are higher across age groups. But in all mild, moderate, and severe CKD. And as you increase the albuminuria, the probabilities are smaller, but still, even in the smallest group, with severe albuminuria, you still have considerable probabilities of recovery, of what's called regression of CKD. We did several group analyses because the journal required, but we had already applied the average method that I said. We restricted the chronicity definition, not just above 3 months, but also 3 months to 15. So we wanted another, an end to the margin of 90 days, because some people might have the first measurement now and then the next measurement in 2 years. So we ignored those cases. This is for the capture of the patient. We saw similar results across groups defined by use of RAS inhibitors previous procedures, vascular, angiography, ED visits in the first year or two, I can't remember. And also we restricted to be event-free for 1 or 2 years and see if regression is still possible. And we found that yes, it is possible, even in those that survive without events and remain in the same stage for at least 1 or 2 years, they can still regress after. So regression is important because it's one of the way people leave the stage of any stage of chronic kidney disease. But if you intend to do a modeling study and see what is the probability of being in a stage and you ignore regression, the probability changes. You see, if you consider regression, the green curve, okay? If you consider regression, the time spent in a stage is shorter, okay? And it's true for mild, it's true for moderate and severe. So that means if we do not consider regression, and I want to do a study where we derive prevalence from our incidence data, and we consider only death and not regression, we're going to overestimate the burden of disease again. So proper assessment of the burden requires implementation of the chronicity criterion. I think this is something important to keep in mind in future studies, and it's not easy using administrative data. I can share some experience in that because it is actually more challenging than we think, how to implement those two methods, sustain and moving average. But we need to do something with that because otherwise our estimates are inflated. In the absence of well-done prevalence studies like the Framingham or something else with a repeated measurement after 3 months, estimates of the CKD burden indirectly requires consideration of all outcomes. Both reduced GFR and albuminuria are key predictors, but lack of specificity of both and association with age of the glomerular filtration rate need to be acknowledged and kept clearly in mind for future research. Okay, now I would like to go to some implication that I would be very happy to hear what you think. But for example, nephrologic criteria without really considering these numbers. This is, again, the same study of the regression where we wanted to look at the distribution of albuminuria by CKD stage, mild, moderate, and severe. So you see that, for example, in severe CKD, there's no really discussion as to whether to refer for GFR of albuminuria because there are so few people, they have reduced GFR, you don't care about albuminuria. So we would agree with anybody to refer a person who has a GFR between 15 and 30, even if there's no albuminuria. But as you go up here, you see that the numbers with normal albuminuria in a moderate CKD, 15 to 45, is very high. And here is impossible to manage. How can a nephrology group take care of all these patients that have a very low risk of progression, very high probability of regression because they don't have albuminuria, right? So some thinking about who should be referred, how can we educate the family physicians considering this data? I would like to hear what you think. My point is we should consider not just the GFR, but also the proteinuria, especially when the GFR is not below 30. And including, this is the second point, to refer back to the GP or find ways to manage with the GP, co-manage people that don't have albuminuria and they have a GFR, a G3 CKD, for example. So the big point is that, you know, except in mild CKD where we don't have data because the G3B after regression would have normal kidney function. And so these people have normal kidney function. And after 5 years, half of the people that regressed from G3A, they are still CKD free. Okay. The people that regressed from moderate, 30% are still in the G3A, because these are improved from moderate. So these are in G3A, and some of them, 7%, don't have CKD anymore. This is improved from severe. So 25% have C3B and 6.5% have C3A. So there's a big trend toward further improvement after an improvement. However, and this is what I honestly didn't expect, the proportion of people that after they experience a temporary, let's call CKD regressed, we cannot ignore that they have a very high probability of dying at 5 years. So who are these people that are more likely to regress because they don't have albuminuria, or they don't have very severe albuminuria? The typical person is a person that doesn't have severe albuminuria, maybe mild, moderate albuminuria, likely to regress. And you're going to send this patient back to the GP, and probably doesn't have kidney problems, but the probability of death at 5 years is very high. And this is something that I really do not have a big explanation unless I link it to the aspecificity of the associations between GFR and outcomes. Accounting for competing risk. Manish had a specific question at a certain point of our email interaction for this talk, and I hope I can either discuss during the presentation or after. So this is a paper that is in press, and it's a validation study. When I published with Cello and Jason a provocatory paper about accounting for mortality, and I was a bit, I criticized a bit the kidney failure risk equation, and I pissed Tangri. Sorry for the terminology, probably gonna get an email about this. And I felt immediately sorry, because that was not my intent. I didn't want to really, but I realized he was more than just upset, and sent some emails like, the two methods, which are the competing risk modeling and the standard cost, should be formally compared and look at the statistics, look at discrimination. And I said, you can't, because one method has, defines outcome 0, 1, the other one defines outcome in a different way. So they cannot really be done. And I tried to reconnect with him, but there's no way to do it. And I'm almost convinced him that there was no way to compare them. But then I got a mathematician as a postdoc, and she said, no, you can, you just fake something. We didn't even tell the journal that we fake something. So you generate some fake numbers in the model of the standard COGS, right? So you pretend that out of 10, 15,000 people, 5 that are sensor reality died. So you can allow a very, very tiny probability. And it's a standard COGS, because it's 5 out of 10,000. Okay, let's try do this. If you tell me this is really a COGS, and then we spoke to statisticians that are expert in the area, and they say it's totally fine, because otherwise every model and every program would say, you're crazy, you cannot compare two things that don't belong together. So this is what we found. So we found that the in development cohort, the standard COGS, which is in this case is an adjusted model. So this is the Kaplan-Meier, so censoring for death versus the cumulative incidence function. There is an overestimation of the risk of kidney failure and the risk of death, okay? To the point that at 8 years in the development cohort and at 6 years in the validation cohort, which is Manitoba, the total probabilities of outcome is above 1 using the naive methods, okay? And then we looked at the calibration and discrimination. So just to make the points clear, And the reason I try to, I learn myself is because you can't imagine how many times I discussed with Nav about this. The calibration addresses the question, okay, I'm in an office. What is the risk of kidney failure of the patient that I have in front of me? So how close is my equation to give me the right number for the patient in front of me? This is the calibration. The discrimination, which is this one, tells you if I have two patients, so let's say Manish is in the next office and Pietro is in this office. So let's do which model, how do the models, the competing risk and the standard, compare in ranking them in the right order? So if one has a higher risk and another one has a lower risk, do these models do a good job in ranking them? Okay. So because Cox doesn't really make a problem in generating hazard ratio and association, it's, you know, the problem with discrimination in ranking is pretty late. It's pretty late. So the Breyer score accounts also for calibration to some extent. But if you look at the just pure discrimination in the development cohort, you don't see much difference in making mistakes in ranking people up to 5 years when you make predictions. In the development is probably sooner, sorry, in the validation happens a little bit sooner, and there is an explanation for that. The Manitoba population has a higher risk of kidney failure, younger, whereas here in the Alberta cohort, the risk of death is higher, relatively higher. So to go back to the calibration, you see for 2 years, there's really no big difference between the standard kidney failure risk equation and the next one that the consortium is working on now, or the one that I am working on now. But even at 4 years, you see this standard cost, this is the orange, whereas the red and the blue are two methods for competing risk. The standard Cox gives an overestimate. So this means, for example, the predicted is around 50%, where the observed is less than 50%, okay? And the things get worse over time. So essentially, kidney failure risk equation is good up to 2 years, but after that, and in people that have higher risk of kidney failure, higher risk of death and kidney failure, problems might arise. I don't waste your time with the reclassification, which requires a little bit of, it's a little bit different than a reclassification improvement, but the results are the same. So I think I want to stop here because I think, I don't know what the time is, but I think it would be better to try to interact and have a kind of a discussion. These are my final key points. So a single EGFR, it's a problem. The regression is as common as progression for mild, moderate CKD, as common as kidney failure in those with severe CKD. With advancing age, the incidence increases, but the probability of regression and death, the risk of death exceed the risk of progression or kidney failure. Younger age, A2, 3 are risk factors. Return to GP paths, like to hear what you say, and accounting for competing risk. Thank you.
Thank you, Pietro. So please, let's open it up for some discussion. You can just speak up or use your hand function, whatever you feel like, and maybe turn on your camera if you have one when you're asking a question.
So I have a whole stack, but I won't monopolize the time, and it's more even some discussion points. But Pietro, thank you for that. That's very interesting. You know, I can't help but be overwhelmed by the fact that they seem at surface level such basic concepts and questions, incident, prevalence, yet they're exceedingly complex when you try to dive beyond the surface and look at all the biases involved. I'll give you an example. When we look at CKD prevalence based on 2 measures in the ICES population, we get ridiculously high numbers in the 20+%. So we know there's some selection bias occurring for people who are having the second measure done. And it makes estimates of what's really happening in the population level so exceedingly difficult. The single measure GFR phenomenon, I see Nephro is, I think, learning and going to 2 measures and doing more accurate means of defining baseline as you recommended. Where I see it notoriously occurring nonstop is the cardiology literature, because they want a convenience cohort of PCI, and so they look at presenting creatinine right when they arrive in the hospital. So they've intermixed AKI and CKD in every prognostic cardiology-based thing. And I bet if somebody worked to tease those 2 apart, I know some people have, but if you worked to tease those out a little more, I bet you'd find something very interesting there among the cardiology literature. This idea of competing risks and return, I think you explained it very nicely. And I do think the KFRE, we use in Ontario, I'm sure as you're aware, the KFRE as the means to entry for the MCK clinic. So we've incorporated it, but these nuances of the risk of death and regression and how to manage them, I think we haven't incorporated or looked into them. And I think research that you're doing and that Dr. Berry's doing are kind of illustrating these points quite well. I didn't really have a question, more a comment, but I just thought that was all very interesting work. Thank you.
Peter?
Hi, Pietro.
Hi.
2 things. One, I like the Iceland analysis, and particularly that in one part of it, they used an age-adjusted cutoff for EGFR. And as a simplistic measure, I wish there was wide uptake of that, because at least it would lower the diagnosis of stage 3 CKD in healthy older people. But that doesn't seem to have had any traction. Nobody seems to be pushing for age-adjusted cutoffs. And I know there was, Classic got that big debate going in BMJ a few years ago that got shut down by the Tangri's group. Has there been any further discussion of that or uptake of that?
Yeah, so I have a paper that I just finished on this, and it just submitted, and I don't want to, I need to shut up because it's, as you said, a very delicate discussion. What I realized is people take it very personally, right? And so one of the very nice things that both Nav and I understood by, working together, let's say working together on this paper, and was, how subtle intellectual bias is beyond any other type of interest. For me, it's very easy to say I have no conflict of interest, but does that mean you don't have intellectual bias? That is different. But yes, so I intentionally de-emphasized my, the numbers of the prevalence in Iceland when they did the age-adapted definition. But what's interesting is that some of the reviewers of these papers, when you work in this area, they come back and ask you. And so this was one of the motivation, as your question, to look at whether the incidence and prevalent incidence, especially because I can do incidence more easily for now, of CKD changes when you account for age. But more for the next talk. I'm sorry, I can't get into details because some people might even be reviewing my paper, so it would be not good, but very interesting.
Hey, Manish, have you done any of these in Ontario, those age-adjusted ones, like Peter was asking in that Iceland study?
We indirectly. So we have estimated incidence in people greater than the age of 65 for the last 5 or 7 years. as part of the prediction equations we're working on to predict new onset CKD, GFR less than 60. And we have incidence estimates between 4 to 7% in that population. That does not account for regression as per Pietro's methodology. But that's what we found, 4 to 7, but we didn't further broken it down by greater than 65 to smaller groups yet, to be done.
Yeah, it's you know, this methodology, just I'm happy to share my experience, is complex because you know, stages are a bit arbitrary cutoffs. But if you ignore stages and you widen the range of GFR to confirm your reduction, you pick up different populations. So it's something that, you know, I would like to keep working with Manish and see if he has other collaboration that can really, we can come up with a strategy to identify these cohorts. Because before we try to address the question, we need to make sure we don't repeat the mistakes already done in the past. Are we selecting the right people to get estimates? Because estimates is the best game you can play, right? To your competing risk regression, you have fun. But if you do it on the wrong population, or it's unclear how this population enter your cohort, it's a problem. You see, Manish mentioned, if I understood correctly, that even using 2 measures, you can still get crazy prevalence numbers just because of selection. So there must be something else. We used outpatient. I don't know if Manish refers to any kind of creatinine, but the reason I focused on outpatient measurements only, only outpatient, is because of this. Because, well, you don't know if people keep going to the hospital. These are different people. Do they reflect really? Because it's enough that few people that go to the hospital is going to change your numbers. So, in fact, the baseline, I just prepared a table 1 for another project, and I found that, for example, the previous days in hospital of the populations that we select, the median is 0. And the interquartile range, it goes from 0 to 8 less than 10. Because this is a population that if you select people that have CKD based on outpatient, stable conditions, they're not crazily hospitalized. I think they are more kind of a reflection of the health status of the population. If you pick up everybody, not that it's wrong, but you need to understand that you are picking up people that might be sicker and might contribute to, might answer a different question. I don't know.
Are you?
Yeah. Thank you, Pietro. That was really great. Thank you for this really nice talk. So we are using eGFR to diagnose CKD. And as you know, eGFR, when you look at data, only 80% are within 30% of the measured GFR.
Yeah.
Don't we need something more to go ahead and diagnose CKD rather than that value, especially in the elderly?
Yes, I agree. But I think first we need to change our mind. And, you know, we need to, you know, even if we love nephrology and we want to be advocate of our patients and, you know, sometimes advocate our research and projects, we need to acknowledge that we need to be better advocate of the null hypothesis in anything that we do. What if is, you know, what if the prevalence is lower? What if, and of course, if you say what if it goes in the other direction, something that you're proposing is more welcome, because then people are seeking for an answer with more freedom. But I feel is not the time, because you have these big names and even, you know, bigger than Nav, the people that work with him. You cannot say age calibration, they kill you, right? You're not allowed to talk. You know, I got reviews, especially one recently. You know, you probably saw the review, Manish, the second paper we have. You know, it's amazing. right? It's really, you see that they are convinced that they know it. So until we try to, get to a more reasonable place to discuss, it's very difficult to propose something different. But, cystatin or whatever you're thinking, yes, I would be happy to see that, right?
Okay, I had another comment. Pietro, so KDIGO recommends consult nephrology when ACR is greater than 30 or eGFR less than 30. And CSN recommended ACR greater than 60 and eGFR less than 30. ACR greater than 60, no matter what the eGFR is. So what do you think about those cutoffs?
Well, it's so from the slide. So my opinion is age is important as well. And there is a big area there that I hope we can do some work. But I think cutoffs for 30 of GFR, I mean, a visit with the nephrologist is not a problem, even if there's no proteinuria. I don't think it's a big problem. Any age, anything, I think a nephrologist should be consulted. But the problem is, what can we do if the GFR is really 20 and the patient is 85 and doesn't have any proteinuria? You discharge these people, and probably is your experience, they come back 1 year later. And maybe the GFR is 25, but because it's less than 30, they come back, right? So I think we need to do something better for these cases, which is the majority. Then 30 to 45, of course, we're talking about not non-GN patients. We're talking about people that probably they have diabetes, they have proteinuria because they have diabetes, or proteinuria because they have hypertension or obesity, but not primary cause, right? So 30 to 45 is a bit tricky, because to me, in the absence of younger age, at least less than 75, that's called younger age for all of us. We're getting, I'm getting close to 60 now. So less than 75 and some proteinuria, I'm okay to see the patient once, and I know you start ACE inhibitors, any protection now, Invokana, whatever. But what do you do if they don't have any albuminuria and they are between 30 and 45? Honestly, I would also, for this patient, I would find a way to follow them with the GP. I mean, you set up a regular blood work every year, and you make yourself available a channel, I don't know, electronically, if there's a way that should be implemented. In Alberta, we are investing millions in Connect Care, in the new EMR method. How come that we don't have a way to interact with the GP quickly through the system, the electronic medical system, with a specific question the GP addressed and done? No referral, no seeing patients, not needed, right? So I think this is the problem. But if there's no channel to go back and communicate with the GP, I don't think it's a waste of time to talk about cutoffs, because the GP will never understand or adhere. Even if they understand, they will not adhere. You need to make yourself available. You need to create a channel first, and then we can discuss about cutoffs. But it's reasonable. If there's no albuminuria, if the patient is not young, or at least less than 75, certainly less than 65, what can we do? Right. I don't know. Does this seem reasonable to you, or what do you think?
Yeah, no, it's very reasonable. As you brought up the issue, many years ago in the Ottawa area, I went ahead and educated so many GPs, and to every GP, I sent the algorithm for referral. Didn't make a difference.
No.
So, it's very hard, because they see an abnormal value and they just triage that this person needs to. From our end, I think that we need to be more pushy, and I really think we need to have a system where tell them, no, do this, this, and this, and if things change, send the patient back to us. But many of us accept that consult and see them, and people argue, well, I adjust their blood pressure medication, or To me, GP can do that too. But anyway, I thank you, Pietro. I agree.
I'm just going to jump in. I even tell Pietro, because there is something. There's e-consult in Ontario, which is where exactly what you're saying. It answers a question. I think Peter and Pierre are involved with it, but they are. The person leading it here, Aaron Keeley, gave a presentation that they're trying to get it in our EMR so that when we get a referral for someone with whatever that really doesn't need to see a nephrologist, instead of we have these things you can accept or reject, they're going to get a new button that says e-consult, so you can kind of click this e-consult and do it that way instead of just getting rid of them or unnecessarily seeing them. So that may change. But I do want to, we only have a few minutes. I see Mark has put his video on. Mark, I know you have some thoughts in this area. Did you want to have a comment or a question?
Yeah, thank you, Pietro. One thing I wondered in the regression in the older people where you saw the death signal, do you think that might be analogous to the U-shaped curve of GFR and mortality from creatinine generation in these people who are maybe not thriving because of another disease state, for example?
So we looked at hospitalization in the previous year, thinking, these people lost weight, these people got amputation, something that you cannot easily find. And even if you excluded hospitalization 1-2 years before, they still have the same kind of outcome. I can add to this that I initially wanted to consider the competing risk of not just death, but also regression when predicting kidney failure, to see if we can do a better job in predicting kidney failure. And predicting regression is more difficult than predicting death. Yeah. I couldn't find, to give you numbers, this is confidential, but I don't think it's a problem to share. But so the kidney failure risk equation variables, okay, even putting a regression model that addresses competing risk properly, they are great. And they are great for kidney failure. You have a C-statistics, which is discrimination, excellent calibration. So first, excellent calibration, and a C-statistics of 85%. In some models, I have 90% calibration. It's crazy. When I show this to friends that are statisticians, they say, never saw survival model with a C-statistic of 90%. Are you sure? Well, yes, because if you think albuminuria, GFR are really mechanistically involved in what's happening to the kidney. So if you use markers that are really primarily kidney-centered, you're going to predict. Then you have age and sex, but those two are going to do a good job. Regression is less than 60, is around 65%. So is really closer to chance, which is 50, than the mid, which is 75. Death, with some work, we can get between 70 and 75%. But what's interesting, Mark, is as time goes by and you plot the C-statistics over time and your ability to predict at baseline in the future, you see that you lose predicting ability for kidney failure. So what's going on there now is good in the short term, but it's getting worse. Still excellent, because at 5 years, C-statistics remain around 85%, 85%, but it's especially high in the first 2 years. With mortality is the opposite. You start from around 70, you go up to 75 as time goes by, even if you do if you account properly for everything. With regression, it's less than 70% always. So we don't know who are these people that have not just a stability of the CKD, but improve in terms of better stage and percentage of GFR. Don't know. We know they have high mortality. It doesn't seem to be related to previous hospitalization. I think this is an example of something that might not be causally related to events. So GFR in this case might just be a marker of health and something that reflects other things that we're not measuring.
Well, Pietro, it is almost 9 here. Thank you for the presentation, and thank you for allowing a lot of time for discussion, which obviously adds to the richness of the talk. And I do hope that we can have this talk and follow up maybe in a year from now.
Yeah, sure.
When it's in real person, and we will take you out to dinner.
Thank you.
Time. And I'm optimistic. I think a year is pretty good. So
yeah,
let's
well,
hope for the best. And again, thank you so much for taking the time. It was an outstanding talk and a great discussion.
thank you.
Thank
Thank
you,
you all.
Pietro. Bye-bye.
I enjoyed too. Bye-bye.
Bye.